It is my honor and pleasure this night to highlight the most updated information about renal transplantation. I'd like to leave the mic to Professor Faissal Shaheen, the moderator of this session, to start the session. Professor Faissal.
Bismillah ar-Rahman ar-Rahim. First, I am very honored today to present my colleague and friend, Prof. Hussein. He is known for all of us, and he is the dynamo of this meeting and lecture, which it will be, inshallah, fi mizan hasanatu. This is in Arabic, because it is a teaching program for our colleague, our young nephrologist, and also our senior one, to know about the up-to-date in nephrology and transplantation. He talked over this e-learning method and webinar, which everyone became interesting to see what's going on, and also to refresh his knowledge again about nephrology and transplantation. Prof. Hussein is very well known, and he is running the e-learning, isn't it? He's a professor of internal medicine in Mansoura, neurology and nephrology in Mansoura, and he is the director of e-learning. He takes the academic of nephrology since 2012 till today. He is a very dynamic person in teaching and very knowledgeable, and I respect actually his knowledge, and I'm sure today we
Thank
will
you very much, Professor.
All of her. He's going to talk
Thank
today
you.
about renal transplantation, what's new and what's hot, and I think this subject is very important for all of us, the nephrologist and transplant physician. I will leave now the mic to him and to learn a lot from him. Please, Prof. Hussein.
Thank you very much, Professor Faissal Shaheen, for this very nice introduction for the session. I think it is my duty, and as you mentioned, it is some new data. So some of them I didn't know before reading. So some of them just, for me, are known since a couple of minutes or hours. So all these are new data in transplantation. I'm going to simplify the issues, to concentrate on the ideas rather than details. So let us start the journey. Before starting the journey, I would like to acknowledge the presence of all my professors and colleagues from Egypt and Arab world, and the moderator, Professor Faissal Shaheen from Saudi. You are welcome, and thank you for moderating this session. This is the outline of my presentation. I'm going to hit 8 corners in the transplantation, starting with the new data from epidemiology and transplant outcome. I selected few. I'm not going to give an overview about transplant outcome. Then the immune suppression, there is no details. Eplet matching and the biomarkers, I think this is one of the very hot issues and new, and I think it creates big debate for its utility in transplant practice. What is the new from pathology corner? Because we know benefit 2019, and what's beyond. And we are living in the era of COVID, so COVID-19 and transplantation, always hot. Then I'm going just to touch hepatitis C and the Clostridium difficile infection, ending with 2 slides about malignancy and the donor side. Let us start with the first part of this presentation about epidemiology and outcome. To start with, from the new data, as you see here, incident in end-stage kidney disease and the prevalent end-stage kidney disease, as you see. I'm not going to highlight the incident, but look at the prevalent. This is the line of transplantation, and this is the line of hemodialysis. This means that we are lagging, and we have expanded pool of patients in waiting for transplantation, either in living donor or cadaveric or deceased donor clean transplantation. A few words about the pre-transplant dialysis duration. We know now that the longer the dialysis before transplantation is, the poorer transplant outcome is. So the message is to hasten and to fast transplantation as we can. From the new update, the issue of association of pre-transplant dialysis exposure with transplant failure is dependent on the state within the United States. So state-specific rate of dialysis mortality, and I'm going to explain what's meant by state-specific rate of dialysis mortality, because United States is continent. If you look here, you will find in different states, there is different data about average dialysis mortality per 1,000 patients per year. It ranges from 215 up to 255. Does this rate affects transplant outcome? Let us see. This is the length of dialysis. So the more the dialysis, this is the color of high dialysis, prolonged dialysis before transplantation. The cumulative incidence of transplant failure is higher with the prolongation of dialysis. And if we look at the quartile of mortality based on this data, this is the lowest quartile and this is the highest quartile of mortality. Again, it affects for some volume the transplant failure. Again, if we look here at the other issue, this is the other of post-transplant outcome based on high quartile and the low quartile. You see here there is a difference between high and low quartile, but the more the prolonged dialysis duration, the worse is the outcome either in high or low quartile. So taking all these together, higher risk of graft failure in the United States in different states with the lowest quartile of dialysis is 4% increased, and 8% increase in highest quartile of dialysis mortality. This means that the survival of the graft is affected by dialysis, either in states with high mortality or lower mortality in dialysis. So it is, as the editorial commented, where quantity and quality, both of them intersect and affect transplant outcome. So this is why we should enhance transplantation. And I think one of the key quality issues in dialysis is to assess the advocation for transplantation. So if I have a dialysis unit with 100 patients, and if you investigate their work and files, and you found 10 patients who are fit for transplant and they are not aware of the issue of failed transplantation, this is a point against the quality of dialysis. So the YBT, what is YBT? It is a randomized controlled trial. Your path to transplant, it is educational. As we are working in education, educating patients, increasing awareness of the presence of transplantation and the transplant outcome. And this is how the design of the study was conducted, either following the standard care, just the same professional way, or to fortify patients with educational activity even through the phone, coaching them. And as you see, the awareness of transplantation increased significantly, either in living donor kidney transplantation or cadaveric one. And if you look here, steps for living donor kidney transplantation, share education material about living donation. If we follow coaching, it increased significantly to the standard of care. Generally, talk to people you trust about whether to get a living donor transplant increased with coaching. Make a list of people who might be living donors increased significantly by education. So it seems that all steps of living donor kidney transplantations are enhanced by education. And although p-value here is insignificant for the cumulative transplantation rate, but I think educating patients for the issue of transplantation and evaluating the patients on dialysis or even before dialysis about transplant choice, I think this is one of our goals, because transplantations, renal transplantation achieves a better quality of life, more physiological because dialysis is unphysiological, associated with better survival. I'm just hitting the issue of mortality based on United States data. What about our experience here at Urology and Referral Center, Mansoura University? Because it is a center dedicated for transplantation. And these are two articles. One is old, since 7 years, and this is the new one in August in Transplantation Journal, reflecting our patient graft survival. If you look at 5-year survival of the patients, 91%, and 10 years, 82%. And for the graft, 82% 5-year graft survival, and 63 10-year graft survival. And I think our half-life is 17 years or something like that. What about the impact of era and the time? Does transplant outcome improve by time, by learning? It is irrational. What about the data? This is the data from the transplant recipient era in Australia and New Zealand over 4 decades, from 80 to 89, 90s, 2000s, and 2010 up to date. As you see, the adjusted 5-year all-cause death rate is reduced. This reflects improvement of the quality of transplant service in this period, in this area. And as you see here, in comparison to, this is the color here reflects the time interval after transplantation. As you see, the current decade is the dark one, improved even in the immediate post-transplant period, improved significantly. As you see, it is U-shaped curve. There is a little bit increased mortality in the first year, and then the flattened of the survival. So, but it is improved in the current era. What are the most common causes of death? As all of us know, cardiovascular death is the most common cause of mortality. As you see, it is significantly reduced by time. And after a period of time, if you look here, both infection-related death and the cancer deaths matched together at this point. So this very huge data for this Australian and New Zealand showed that the primary analysis was death was graft function, all cause and cause-specific death rate, cardiovascular, infection, cancer death have all declined significantly over 40 years in the early and late periods of post-transplantation, and this is good news. What about this? Is the fantastic. What is the issue of donor age, donor recipient size mismatch? Does age affect the mismatched donor and recipient in size and surface area? Let us look at this is the one of the very recent data. So this is the donor age below 40, 40 to 49, 50 to 59, and above 60. And this is donor recipient body surface area, either matched or mismatched, above 1 or less than 0.8. If you go in the young donor, below 40, you'll find here, irrespective to the recipient age, here this is the age of the recipient is 18 to 30, 70%, 30 to 40, 81%, 85, 88, 90. If you look to the values, if the matches is less 0.8, you will find it is the same so long as the donor age is below 40. If you go, for example, here, for donor above 60, you'll find disparity if there is mismatch between the donor and recipient. So the association of the donor recipient size mismatch on long-term survival may be modulated by recipient and donor age. A size mismatched young donor is associated with equal or better estimated long-term graft survival rates than size matched kidney from donor aged over 40 years. So this is why we should look at the demographics of our patients. One of very important and interesting data, although it includes few number of patients, 55 patients, and I think Professor Halawa will be interested in this article. Intra-abdominal hypertension. All of us are aware by intra-abdominal hypertension in clinical nephrology because it is one of the reasons and the causes of acute kidney injury. And even if we diagnose acute the intra-abdominal hypertension or abdominal compartmental syndrome after surgery, this may be an indication for reoperation for the patient in general. Let us see here intra-abdominal hypertension early post-kidney transplantation period. And is it associated with, is it common? Is it associated with problems of graft function? Let us see. Intravesical pressure in the bladder, urinary bladder, is monitored every 8 hours from day 0 to day 3. And the intra-abdominal hypertension was defined according to the World Society of Abdominal Compartment Syndrome as an increase in intra-abdominal pressure reflected by the bladder pressure, either above 12 millimeter, if it is above 12 millimeter mercury for more than 24 hours, and degraded, grade 1, if the pressure between 12 to 15, grade 2, from 16 to 20, 3, 21 to 25, grade 4, which is very significant, if the pressure inside the urinary bladder exceeds 25 millimeter mercury. Why it is important? Is it because surgery? No. It is because of our care as nephrologists, because usually we hydrate the patient too much, high pressure. If we look at the patients, no intra-abdominal hypertension, grade 1, 2, 3, and 4, you will find almost 75% of the patients of these 55 have degree from intra-abdominal hypertension. And this is what this study adds, although as I mentioned, it is just small sample size, 55 patients, and we are waiting further studies. Almost 75% of patients experiment intra-abdominal hypertension in the early post-kidney transplant period. Intra-abdominal hypertension grade 3 and 4, almost 30%, 1/3 of the patients are independently associated with impaired graft function recovery. Intra-abdominal hypertension development is associated with higher fluid balance after kidney transplantation. I think if the results of this study is replicated in a bigger sample size, we should pay attention very much to fluids given to the patients, and we can monitor the pressure by urinary bladder manometry, and it will help to detect intra-abdominal hypertension to consider one of important issue in graft function. Okay. Regarding immune suppression, I think this is the very important regarding induction. The question is, where do we stand in 2020 regarding induction therapy after kidney transplantation? As I discussed with Professor Halawa last week, the issue of induction is not evidence-based. It is just on individualized and center preference and according to the immunological risk of the patients, and we discuss the issue of basiliximab. But let us look at this big data. 55,000 adult diseased donor kidney transplant recipients, huge data. Induction therapy, here they categorize patients into two big categories. Calculated BRA from 0 to 9% and from 10 to 79%. And then the induction, either ATG, 25,000 here, 7,000 here, alemtuzumab. I think alemtuzumab is declining everywhere, and I think it is restricted nowadays to oncology. But we have some experience with Canvas or alemtuzumab in humble study. So alemtuzumab here 7,000, almost 2,000. Interleukin-2 receptor antagonist, 11,000, 1,600 patients. So it is data registry, very important. If you go to the numbers regarding if calculated BRA is less than 10%, and here you can look at graft loss by different overall or death-censored or patient death, and you can look at the hazard risk. Hazard risk is here, the range is between 0.9 to 1. This means insignificant. P-value is insignificant, 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 and just borderline insignificant. This means if we take everything at this in comparison of ATG versus interleukin-2 receptor antagonist. For alemtuzumab versus interleukin-2 receptor antagonist, p-value here insignificant, but p-value here is significant if we use propensity scoring. The graft loss is higher with alemtuzumab, and the confidence is above 1. This means it is less than. So alemtuzumab is less benefit in comparison to interleukin-2 receptor antagonist regarding graft loss. P-value here is significant, the same. Alemtuzumab is associated with worse outcome, and here no difference in p-value. ATG versus alemtuzumab, again the same. ATG is superior because the hazards is less than 1, So this means graft loss, either censored or not, is significantly better with ATG in comparison to basiliximab. And this is regarding patients with calculated BRA less than 10%. What about calculated BRA between 9 to 79%? You'll find here the hazard risk, almost no significant difference. So this increases the doubt about the value of routine induction therapy of the patients. And this is the delayed graft function biopsy. You'll find the biopsy higher with interleukin-2 receptor antagonist. And then the issue of malignancy. And I recommend this article because it includes huge data about cadaveric transplantation for induction therapy. Regarding maintenance immune suppressive drugs, I think we got through these two Zooms in May and June, 4 hours, about maintenance immune suppressive drugs. So I'm not going to discuss them in details, but I'm going to mention some new updates in the field, in the issue of immune suppressive drugs. Tacrolimus is now considered the backbone of maintenance immune suppressive therapy. And here I would like to highlight on IBV, this is intra-patient variability. We have intra-patient variability between inside the same patient, and inter-patient variability of level between different recipients. So the determinants of intra-patient variabilities is food and drug. As I mentioned before, in the zone of maintenance therapy, food reduces the bioavailability of tacrolimus by 30%. So if I am the same patient, and today I take the tacrolimus with food, and the next visit I'm going to take it on empty stomach, you will find different level because bioavailability is affected by food. Genetic factor, I think genetic factors will affect the inter-patient variability because every person has his unique genetics that determine absorption and metabolism of the drug. Medication non-adherence, it is very important because I think it is modifiable and it needs improvement. Concomitant illness like diarrhea, and diarrhea is associated with increased level of tacrolimus because, as Professor Halawa mentioned in one of his Zooms, that the intestine is responsible for excretion of tacrolimus. If we have poor intestine, the level will be elevated. And I would like to add, it's not excretion, but also the metabolism. Cytochrome B system is also present in the intestine, so intestine shares the metabolism of tacrolimus. So all these are determinants of patient variability regarding tacrolimus. If we have high variability, this is why we should look at the serial level of tacrolimus, trying to have the therapeutic target all through the follow-up of the patients. And if there is high tacrolimus intra-patient variability, we may expect rejection, development of de novo DSA, and this is for the low level, and for the high level, histological lesions of drug toxicity. And ultimately, all these factors can lead to graft loss. And I would like to stress again on medication adherence to educate the patients from 0 point before transplantation about the necessity of adherence to immune suppressive drugs to avoid the mare of rejection and graft loss. Regarding the genetic makeup of any individuals control absorption through this ABCB or multi-drug resistant gene, and the metabolism cytochrome B3A5, which is responsible out tacrolimus. I would like to comment on one of our work that was published in August about cytochrome B3A5 gene-guided tacrolimus treatment of living donor Egyptian kidney transplant patients. This work was done in collaboration with this center in Greece. So the method in this study, we determined the allelic frequency of cytochrome B3A5 star 3, and this denotes a slow metabolizer because star 1 is a fast metabolizer. So this is non-expressor in 76 renal transplanted patients of Egyptian descent. Secondly, we evaluated the influence of cytochrome B3A5 gene variant on tacrolimus doses required for these patients, as well as on dose-adjusted tacrolimus trough concentrations. This is the methodology, BCR restriction fragment length polymorphism. I'm not going to bother you by the methodology details, but look at the results. The majority of our patients are homozygous non-expressor. 72% of this cohort was non-expressor, and 26% heterozygous, star 1 and star 3, and only this fraction 1.3% is homozygous expressor for cytochrome B system. What is the impact of this on dosages of tacrolimus? From the start point, if you look here, concentration dose ratio. If concentration dose ratio is high, this means that the metabolism is slow. So in comparison to those who are either heterozygous, these are the heterozygous group. You see here concentration is at the first time is low and after year is low. This means that the cytochrome B system affects tacrolimus, the dose. This is a very nice article because it addresses all issues related to tacrolimus and other immune suppressive drugs, and commenting on the modified release or extended release. This is a question. If we are advocating extended release tacrolimus as 1 dose per day to improve drug adherence and to reduce variability, is there any pharmacological difference between immediate release tacrolimus and extended release tacrolimus? This is a very nice case report. Showed that if the patient is treated with anti-epileptic like phenytoin, which is enzyme inducer, and then we shift from immediate release to extended release, in this case scenario, the lesson is that the phenytoin, which is enzyme inducer, after shifting from immediate release to extended release, there was a big failure to maintain therapeutic value level of the tacrolimus. Why? Because it is well known that immediate release is associated with higher level, and extended release, it is not high level, but it's sustained for a long period. This is why we prefer extended release if the patient has tremor, because tremor is related to the immediate release peak effect. Yes, extended release has lower peak, but the problem is if the patient is treated with enzyme inducer, there may be difficulty to attain therapeutic level. To put this in mind, because there is some difference between these. Regarding the issue of gut microbiome, and this is one of the very hot issue not in transplantation, in medicine in general, to deal with the gut. This is one of the mechanisms beyond the hyperglycemia, is tacrolimus reduces some gut bacteria I'm going to mention in this cartoon. Tacrolimus reduce the bacteria producing butyrate, and this will reduce glucagon-like peptide 1. So butyrate is reduced within the gastrointestinal tract and mainly in the cecum, and this will be reflected on hyperglycemia because of resistance, insulin resistance, and reduction of glucagon-like peptide 1. And in this experimental animal model, when if you look here to the oral glucose tolerance, tacrolimus is associated with hyperglycemia, and here tacrolimus is associated with high A1C. If rat is fed on butyrate plus tacrolimus, here we'll find this is tacrolimus butyrate. They ameliorated the hyperglycemic effect of tacrolimus either by A1C or oral glucose tolerance test. So this means that dysbiosis or gut microbiome, it changes are important. So this is the summary systematic review of 13 studies about enteric dysbiosis and the kidney transplant recipient. And this is how both of them affect other, because there is a bidirectional relationship. So immune suppression and transplantation affects gut microbiome, and the gut microbiome affects transplantation. These are the factors: pre-transplant, transplantation practices, antimicrobial treatment, primary indications for transplantation, mild atherosclerotic disease, infection. All these are factors pre-transplant that affect the gut microbiome. Immune suppressive drugs, perioperative antibiotics, viral drugs, endoscopic retrograde cholangiopancreatogram, non-estomatic structural infection. All these are post-transplant, and this is the how the issue is going. And reported post-transplant complication. All these can explain the interrelationship between gut microbiome and the kidney transplantation. I'm going to continue my journey in this update by targeting the Eplet matching and the biomarkers. I think this is one of the hot and updated issues. What about Eplet matching? When we do tissue typing, we concentrate on the allele in the HLA typing. But HLA, if we say HLA, the surface that contains amino acids, and the unit, small unit of the HLA is Eplet or epitope. So it is gathering of some amino acids that may be antigenic or immunogenic. So the surface can include large or few Eplets that determine the Eplet matching. So if we concentrate on the high molecular, high resolution matching instead of the antigen toward the Eplet, this may make a difference. And for example, this is the two couples for HLA-DQ antigen mismatch. This is one antigen mismatch. This is the by traditional way. But if you look at the Eplet, the epitope mismatch, you'll find here this ranges from very low mismatch up to very high mismatch, although they are one mismatch by the antigen method. And the second mismatch, even here, there is two mismatch in the HLA-DQ locus between recipient and donor, but you can find the variability for donors who may have low Eplet mismatch to those who have high mismatches. So depending upon the traditional method, it will not reflect the reality. So, and this is another data showing the same concept. If we consider this is HLA DQ8 recipient, and these are two persons. This is DQ5 and DQ9. Both of them are not matching with DQ, but in this is the, if we look at the HLA antigen, it is one mismatch. But if we look at the Eplet mismatch, we will find 27 mismatch if we consider DQ5 for DQ8 in this example. But DQ9, although it is the same one mismatch by the traditional HLA mismatch, but Eplet mismatch is just 2. So there is a great difference between 27 mismatches to 2 mismatches. This is why changing from traditional one to the molecular Eplet mismatch may be more important by quantifying a molecular mismatch, because it has been shown to correlate with de novo DSA development, T-cell mediated rejection, antibody mediated rejection, and allograft survival. Recent studies suggest that HLA molecular mismatch may be both a prognostic and predictive biomarker in transplantation. However, it is not available everywhere and needs validation. For example, we don't do HLA-DQ in our center routine, but if the recipient has anti-HLA and DQ in the serum bioluminex, we review the HLA typing of the donor because of the economic reasons. This is another study showing the Eplet mismatch load and the occurrence of the SCA. And as you see here, we have Eplet mismatch for HLA-A, B, C, DRB, DRQ, A1, B1, and others. If you look at the bold one, DQ, you'll find it correlates with de novo DSA, any rejection, graft function, and graft failure. So antibody verified Eplet mismatches in HLA-DQ confer substantial risk for de novo DSA, graft rejection, graft function, and graft failure to be put in mind. This is why the editor of this article put this under the title Renaissance. Renaissance means progress. This is how we are going to evaluate. And if we apply the molecular pathway, it will improve and refine the risk evaluation. Regarding TTV as a biomarker, TTV is a virus, torque-tinovirus. It is a virus that reflects the immune suppressiveness. So it increases, its level increases with the degree of immune suppression. And if the immune suppressive dose is not adequate, you will find it is reduced. So it may be, and it has no pathology in human. So it may be used as a marker for immune suppression. And this is a very interesting study, including 2 cohorts, biopsy cohort and infection cohort, and the total cohort is 386 recipients. And this is in this study, they evaluated TTV serially, as you see in these months, and then they found that TTV load between million and 100 million copies per milliliter are fantastic. If we go below 1 million, the patient will have rejection. Above 100 million, the patient will have over-immune suppression. This is a very nice study because it includes 3,000 measurements in this 300 cohort patients, to the extent that this virus load can be considered a surrogate marker for the native state of immune suppression. We need it to be in this range between million to 100 million copies per milliliter. This stimulates us, and this is one of the MD nephrology assignments, and this is a review just accepted in the experimental journal, torque-tinovirus PCR titer, a promising immunometry. It's a review article. What about donor-derived circulating free DNA? I like it, and I find I always consider it fantastic and interesting. Why? Because we have the donor kidney. When there is an inflammation, then the DNA of the donor will be elevated in the blood. So at the time of transplantation, you will find higher level of donor-derived circulating free DNA. And after that, vanished. When the graft is exposed to rejection, it elevates. And there is another very nice article about we can use it serially to monitor treatment. So if we give anti-rejection and still graft dysfunction is persistent, then we are not sure if rejection process is still working or it is the result and consequence of rejection, graft dysfunction. So if the donor-derived circulating free DNA dropped, this means that the immunological process went. So all these are the interesting and the hypotheses. But let us look at this study. I like it because always the wisdom comes from extensive reading and exposure. So this is a very nice study published in the NEDT from 107 kidney transplant recipients. Plasma samples were collected longitudinal after transplantation from day 1 to 3 months within multi-center setup. And as you see, the dotted line is donor-derived circulating free DNA. It doesn't differ from serum creatinine. It doesn't add anything. So although biomarkers are attractive, interesting, fantastic, but we need further tests before indulging them into practice. This is another study, still in the accepted form, and donor-derived cell-free DNA can be a helpful marker for diagnosis of antibody-mediated rejection among those recipients suspected of renal dysfunction. But the problem is the diagnostic accuracy on the main rejection episodes remain uncertain. But this is a positive study published in the American Journal of Transplantation this month about high level of donor-derived circulating free DNA in patients with T-cell mediated rejection 1A and borderline allograft. If we look here for this 79 patients, we have low donor-derived circulating free DNA and high subcategories. So for the change in estimated GFR and the creatinine, you will find here the lower one is the higher donor-derived circulating free DNA group had very significant reduction of kidney function, estimated GFR, and the percent of change in estimated GFR after from 3 to 6 months. Also, presence of donor-specific antibody increased here 2.7% in the low group in comparison to 40%, and recurrent rejection 20% in comparison to 0. This means that the higher level of donor-derived circulating free DNA predicts the outcome, graft function, and development of rejection and presence of donor-specific antibody. What's about immuno? Immuno, it is testing the capability of T helper cell to produce ATP ex vivo. So we need ATP to be within therapeutic range. The higher the ATP reflects, the more active T helper cell. And if the patient has higher level of ATP, this is a risk of rejection. And if it is very low value, this means that T helper cell is suppressed completely, and the patient may be at risk of over-immune suppression and rejection. And this is a study in cardiac transplantation showing that the level of ATP by immunotesting Silex ATP measurement was it's nadir at the time of infection and increased with recovery of infection. MicroRNA. I know it is very difficult part, and this is why I put it in the middle. MicroRNA are small single-stranded non-coding RNA molecules between 19 to 25 nucleotides in length that bind to target messenger RNA transcripts, inhibiting their translation. What is their value? I think this is a very troublesome figure because all cells can have microRNA. Some of them is linked to rejection. Some of them is linked to tolerance. And this is the diagnostic application of microRNA. Regulation of biological process, cell differentiation proliferation, activation and regulation of inflammatory response, could be potential non-invasive biomarker for early recognition of acute rejection associated with tolerance status, avoiding tissue biopsies. And this is one of the merits and advantages of any biomarker if it is validated, how to replace the invasiveness of renal biopsy by the biomarker in serum or urine. Extraction and quantification of microRNA can be completed within 1 day. All these are advantage. Antisense oligonucleotides suppressing specific microRNA could reduce allograft rejection. Combined microRNA-based therapies, so the microRNAs may be used as diagnostic and therapeutic too. And this is the part from the table showing the correlation with acute allograft rejection and chronic allograft rejection. What is this? This is the correlation of microRNA with ischemia reperfusion injury. With ischemia reperfusion injury, there is increase of 2 microRNA. So hypoxia increases microRNA 24 and 145. Both of them reduce the machinery of antioxidant activity, and this will lead to ischemia reperfusion injury. And if we block these 2 microRNA, it may ameliorate the ischemia reperfusion injury. I think all biomarkers are a way toward precision medicine, and the most published studies have focused on prediction and the correlation with clinical outcome rather than to prospectively guide immunosuppressive therapy. A lack of mature precision dosing protocols applicable in the clinical settings calls for future development and research. All these are ideas and hypotheses. Can we use biomarkers to delineate the issue of borderline? Because borderline is associated with poorer graft outcome. However, isolated tubulitis appear to have similar prognosis to normal biopsy in some patients. It remains unclear if all borderline change should be treated, but we treat them if they are associated with graft dysfunction. Can we use biomarkers like genetic, circulating free DNA, and others to predict the rejection and to replace surveillance kidney biopsies in these patients? I think this is a hot issue, need further clarification. Regarding pathology, I would like to appreciate and acknowledge Professor Hussein Ismail for delivering 4 Zooms in just 2 months ago, 8 hours, discussing all issues about the application of the biopsy and histopathology examination in transplantation assessment. In the current issue of American Journal of Transplantation, there are many articles about pathology and advances in pathology. I'm not going to represent them in details, but pamphlet 2019 is detailed in this article, and I'm not going to discuss pamphlet 2019 because it was discussed elegantly by Professor Wissam, but here regarding the issue of electron microscope. Take a sample in all cases if possible, fixed and embedded as a resin block at a minimum. This could be done if there is any suspicion of glomerular disease, while EM can be performed on samples recovered from paraffin blocks or frozen tissue to examine for electron density deposit and to some extent the degree of food process effacement. This is not recommended for assessment of glomerular basement membrane thickness and the multi-layering of tubular capillaries. So it is better to reserve sample for AM even if it is not done. And it is recommended in these cases light microscope and or histochemical suspicion of glomerular disease or other diseases that were assessed in the diagnosis. Patients at risk of antibody-mediated rejection, like sensitized patients, and in the presence of the glomerulitis and hepatocellular capillaritis, and it may be of value for diagnosing recurrence, and it may be of value if the biopsy is done late after 1 year of transplantation. And Professor Richard Glassock, during his talk in NephroAlex 2 days ago, he stressed upon the electron microscope in evaluating focal and segmental glomerulosclerosis. And if we want to diagnose recurrence of FSGS post-transplantation, looking at effacement of food process, this is with proteinuria, it is a clue for the recurrence. And even diffuse effacement of food process, if we depend upon protocol biopsy, may predict recurrence before the clinical presentation. This is why if the cause of graft failure is glomerular disease, AM should be considered. The advances, and we have Professor Akl with us this night, and molecular diagnosis, how use molecular, and it is very difficult for me to grasp all the genetic and signature within this BAMF. So the molecular diagnostic and solid organ transplant consensus for BAMF, human organ transplant, be hot gene panel, and it is a very nice and fantastic because it addresses many, and this is depend upon it is paraffin or fresh tissue, so we can reach 47,000 transcripts, and this table summarizes the difference between the two methods. I'm not going to bother you by all these, but at the end of the day, within the molecular testing of the histology, we can know the genes that can guide us for treatment. I think it is still for research, needs further validation because it is very difficult for us to have. But this is a very nice study away from the BAMF. It is intragraft transcription signature in antibody-mediated rejection. Irrespective to the presence of DSA, the genetic makeup, because we may have antibody-mediated rejection and DSA is negative completely in the serum, so the transcripts will help us for the diagnosis of antibody-mediated rejection. Digitalization, technology of digitalization and the refinement of reading of tissues. So digital automation of pathology practice and computing and using nanotechnology, machine learning, slide enumeration, all this may be for future to improve the interpretation. For indication biopsies, if we have graft dysfunction and we decided for biopsy, indication biopsies performed early after kidney transplantation reveals a significant percentage of inflammation. And the inflammation within this early period of transplantation is linked to HLA-DR mismatch and the presence of pre-transplant HLA-DSA. As you see, this is the 1.3 and this is 3.9. But for the donor age, donor type, cold ischemia, asystolic ischemic time, and anastomotic time, all these were not significant. This means that inflammation is linked to immunological matches. What about the presence of inflammation in area of fibrosis? This is a DCAF prospective cohort study showing that if we have inflammation in the area of fibrosis, IFTA, this is bad news. And the higher the degree of IFTA, the higher the score of IFTA, the poorer the prognosis of the graft. The same for tubulitis in the area of fibrosis. The presence is bad news, and the higher the score of TFTA, the poorer the prognosis. And I think this slide shows the percent of graft survival. It is the best, and this is the years, it is the best when there is no inflammation and no rejection. And the combination of inflammation and rejection carry a poorer prognosis. IgE, I think this is another new, fresh, that mast cell and the basophil and the IgE may be component with antibody-mediated rejection. We are waiting further value of this. Let us go to one of the most hot corners in the transplantation update, which is COVID-19. This is one of the studies about the COVID in kidney transplant recipients, incidence and clinical outcome. This is the 5%, and this is higher than general population. So kidney transplant patients had an elevated risk of COVID-19 if they were non-white and had comorbidities such as obesity, diabetes, or asthma, and chronic pulmonary disease. Those who were diagnosed with COVID had 24% mortality rate. So mortality is high according to this study. And this is the outcome of the patients. AKI, renal replacement therapy required, died and recovered. And you can look here at the patients either on invasive ventilation or non-invasive ventilation. You'll find here if the patient in invasive ventilation, all these are increased. Another study from USA, COVID and the kidney transplantation in USA, and this is how the design is done and conducted. After propensity scoring to match 288 COVID-19 infected, critically ill, non-transplanted patient, and here the transplanted patients were 98, so almost 100 transplant compared to the well-matched 200 or 300 non-transplanted patients with severe COVID. There is no difference. P-value in this cohort of patients with propensity matching, there is no difference regarding death, need of mechanical ventilation, ECMO, RRT, acute respiratory syndrome, thrombosis. So this is to the contrary of the previous one. There is no difference in transplant or non-transplant. I think one of the very important cohort from French registry data showed that how immune suppressive managed withdrawal of antimetabolites is 70%, and the calcium inhibitor according to the severity of the disease. These are the different drugs used for repurposing, but which is very important is bacterial infection occurs in 23%, other viral infection, fungal infection, need for oxygen therapy, ventilation, and others in this table. So just to show the importance of this cohort, because it has a data for 279 recipients. 36 of them were treated at home, like the cohort of Professor Halawa. And here, 243 either severe disease or non-severe disease and treated in hospital. And the risk factors, the most important here, 30-day mortality, 22%, very high mortality. And risk factors for severe disease includes obesity, the presentation with fever and dyspnea. So COVID-19 in kidney transplant recipients portends a high mortality rate. Risk factors for severe disease are close to those of the general population. Proper management of immune suppression and tailored treatment with this population remains challenging. This is the case. This patient has severe rejection. This is C4D, so this antibody-mediated rejection. The patient treated with cocktail, including rituximab. And after a period of time, the patient presents with graft dysfunction and collapsing variety, collapsing glomerulosclerosis after transplantation. And when CD19, which reflects B cell, it was negative. This means that rituximab was associated with prolonged lymphopenia. So this is a case of COVID-related collapsing glomerulopathy in kidney transplantation. This is the cohort of collapsing variety in African American outside transplantation, 60 cases. And here, collapsing was linked to the homozygous ABL gene. But in this transplant case, it was not a low risk ABL gene. Another study showing 3 cases, T-cell-mediated rejection, cortical infarction, acute tubular injury after COVID in transplant patients. This is a case report, and this is a CT scan. I think all of us see this. This is non-perfused parts. So it is renal infarction. So we shouldn't forget thrombogenesis that may be ameliorated by the use of anticoagulation. This is our algorithm that will appear in the Egyptian Journal of Egyptian Society in the October issue. And I like to give a time for this algorithm because I like it, and I'd like to hear from you your opinion about this algorithm. So if we have COVID-19 infected kidney transplant recipients with positive swab, then we evaluate if there is lung infiltrates or no. If there is no lung infiltrates, we can continue the same immune suppressive regimen. We don't like to lose the graft. Half or stop antiproliferative doses in presence of comorbidities. So continue the regimen in general, but if the patient is old age, above 65, diabetic, or has cardiovascular disease, we reduce the antiproliferative drugs. If there is lung infiltrates and no fever, no hypoxia, continue oral prednisolone 10 milligram, continue tacrolimus targeting a level between 4 to 6, and stop antiproliferative. If no response within 3 days or deterioration of the case, stop tacrolimus. If there is lung infiltrate with the presence of comorbidities age above 65, diabetes, cardiovascular disease, or high-grade fever or hypoxemia, give oral prednisolone 10 milligram, continue TAC for in the level 3 to 4 instead of 4 to 6, stop antiproliferative, and if no response within 3 days or any deterioration, stop tacrolimus. This is a proposed approach by our group, and I think it has some advantages and disadvantages, everything. The barriers for COVID, disposition of drug, access and adherence, patient-related challenges, transplant center-related challenge. I think the strategies is optimization of telemedicine and telehealth, remote monitoring of the patients, and strategies to enhance medication access, strategies to deal with the stress and anxiety and depression. Few words about hepatitis C. This is the guidelines, Kiduki commentary on KDIGO. They suggested that all conventional immune suppression, either induction or maintenance, can be used in hepatitis C recipient. This is a very interesting multi-center study to transplant hepatitis C infected kidneys. This is an open label study of combined GB, glecaprevir, and bebrinazavir. These are direct antiviral drugs that can be used against hepatitis C even in the presence of CKD to treat recipients of transplanted kidneys from deceased donor with hepatitis C virus infection. The number of the couple here, 30 hepatitis C virus viremic kidney from donor who has positive viremia, PCR, to a recipient who is negative. And then the figure 3, within from the day 3, the patient is treated with this combination, GB combination, once daily for 8 weeks. And this is the sustained viremic response up to 12 weeks after treatment. 97% patient graft survival, no clinical liver function. And after 6 months, there was excellent allograft function. As I mentioned, figure 3, so there are 3 cases of acute rejection and 3 cases of BK viremia in this cohort of patients. Don't forget that this is cadaveric. I didn't agree at all for doing the same in living donor kidney transplantation because I think this is a completely different environment. Regarding Clostridium difficile, I bought it because we had a debate in one of our Zoom how to treat Clostridium difficile infection. And this is the methodology: reduction of immune suppression if it is mild case, discontinue of systemic antibiotic, de-escalation in the spectrum because the use of antibiotic is the reason behind increasing Clostridium difficile. Vancomycin is the drug of choice, oral in this dose, or another drug is fidaxomicin, 200 milligram for this period. In patients who have an identified microbiological confirmed infection, required continuation of systemic antibiotics, secondary prophylaxis therapy can be considered if the patient has high risk factors for poor prognosis. What about metronidazole? Metronidazole can be utilized for treatment if neither fidaxomicin or vancomycin are available, but not as a preferred therapy. Can be used intravenous in the fulminant cases. One slide for post-transplant malignancy. one of the very important line of treatment of cancer that is currently available is checkpoint inhibitors or immunotherapy. And this is a systematic review showing the survival probability, either if we use this checkpoint inhibitors are drugs that stimulate immunity. And stimulation of immunity in transplanted patient will be complicated by rejection. So if there is no rejection, this is a time survival, this number of weeks. If there is a rejection, the survival is reduced. The most important issue in decision for using checkpoint inhibitor or not in transplantation, I think it depends upon individualization. And the primum non nocere, this means do no harm, is the rule. If we have renal transplant recipients, we can manipulate immune suppressive drugs and giving immune checkpoint inhibitor for treating lung cancer or melanoma. Even if graft failure occurs, we can do dialysis. But if the patient is liver transplant or cardiac transplant and then liver or heart failed because of immunotherapy, it will be a great problem. So the message is, before giving this line of treatment, which is fantastic, but is not without side effects, we should discuss with oncologists and with the patient and the issue of wisdom. And we shouldn't forget do no harm. For donor, it's only one slide. Use of dietary supplements in living kidney donors, a critical review. It's very interesting because even garlic, which is taken as food supplements, and food supplements in the United States are not under the regulation of FDA. So garlic can lead to bleeding because it inhibits platelets. And if the donor is treated by any drugs, it can, after donation, it can lead to drug-drug interactions. And even this is the ginger associated with reduction in fasting blood glucose and the bleeding too. So the wisdom post-donation management after hospital discharge recommended avoidance of routine use of dietary supplements after kidney donation. I should stop here to allow, I think it is a heavy dose from the update, but I try to simplify it because knowledge is no value unless we practice it. And the great aim of education is not knowledge, but an action. I think many of the ideas that I mentioned today are just for research purposes and to improve, trying to improve the outcome of the patients. And I am very proud that I'm a member of this fascinating team, Mansoura Urology and Nephro Center, led by Professor Ghunaim, Professor Sobh, and this Professor Ayman, the chief of the unit nowadays, and all my professors and colleagues. This is the number of transplantations that we had up to the March this year, because in COVID, everything was locked, but we returned once weekly since a couple of weeks. So I am ready for any questions and any comments. Thank you very much.
Thank you, Professor Hussein, for this excellent talk. And I'm very happy to hear the new things coming from you, up to date, actually. You are usually up to date. I wonder because I am the moderator here, so I will take the chance and just ask few questions, if you don't mind.
Yes, please.
Yes, I would like you, if possible, to give an idea about withdrawal of immunosuppression drug post-transplant with the graft failure, because still there is no protocol, a special protocol for that, and everyone is doing according to what he thinks it is right for the patient. So either to give, to withdraw one by one, or to withdraw all together, or to take it slowly and give them in a low dose of steroid. This is probably one of the points which I would like you to show because of our young colleague and ourselves as well. And I like the idea of education. I am sure that you are aware that many hospital or many center, they are taking the CKD stage 5 and give them education by the nephrologist, by the vascular surgeon, social worker, all sit together and give them the option of the future, either to go for dialysis, BD, or transplantation, and to choose for them probably the right way to go and explain to them before they reach to the stage where they require renal replacement therapy. And again, sorry for this, considered as questions or comment. Again, before we were thinking that improvement of kidney transplantation, it is improvement of immunosuppression and preservation of the organ. But nowadays, I agree with you that immunology considered to be the third important part for improvement the outcome of the transplantation. I don't know either you agree with me about this or not. This is from my side, and then we will open the discussion for our colleague from Arab world and also from Egypt. So if anyone, we don't have a lot of questions. Maybe Dr. Akl, welcome Dr. Akl. He wrote one question, but I will probably, he can raise it to you directly. Please, Prof.
Okay, thank you very much, Professor Faissal, for these points. Actually, it is difficult for me to disagree with your concepts. I always agree with you, but regarding failing graft, this is a very hot issue, and to the extent that even in our center, our policy in the past was to stop immune suppressive so long as the graft fails. And we reviewed this policy because it is completely nonsense. So, and it increases the likelihood of development of sensitization and anti-Chill antibodies. This is why we have our own protocol, and I uploaded it to the SNT Virtual Academy, and I think it is fresh within a couple of months, because this was one of the pitfalls of our management is stopping the all immune suppression. This will increase development of antibody. So long as if the patient is the patient will be prepared for the second transplant, it's better to continue immune suppressive drugs. The dose and the type of immune suppression differ from center to center. So we don't like calcineurin inhibitors, for example. So you can find some consultants advising to stop calcineurin inhibitor, because after stopping calcineurin inhibitors, you'll find a reduction of creatinine and keeping the residual kidney function. But I myself, I prefer to stop first antiproliferative, because antiproliferative will increase infection. So this is why you'll find the difference in the attitude and the practice from place to place. This is why we sit together, discussed every point, and we have our protocol how to manipulate immune suppression in the presence of graft failure, and I can forward this protocol to you. Regarding the second point, education, I am a great believer in education for doctors, for nurses, and for patients. And for transplantation itself, I presented here some educational activities for the patients in a randomized controlled study, path to transplantation. But in the Western community, they had the advocate of transplantation who advocate for transplantation and educate the people toward the benefits and the precautions of transplantation. And this person is not necessarily to be doctor or physician, maybe a nurse, maybe a clinical pharmacist, but should be trained, educated for the aim of advocacy for transplantation. Immunology. It is mysterious, and I think to improve the transplant, we should know a lot about immunology, because still what we know is very limited. We don't have an accurate immunometry. All biomarkers that I mentioned are needing, some centers prefer, for example, Silex and Immuno, and to measure ATP, and they want ATP to be within therapeutic range. Yes, it's okay beside drug levels, But at this moment, there is no single ideal biomarkers to be used. This means that in the immunology, I think immunology is one of the most important corners, needs refinement and improvement.
Okay.
And immunology and the biomarkers, and I think Dr. Akl, Professor Akl agree with me about this point because he is fond of transplant immunology and he has advances in the monitoring and the regulatory cells and others. So I think immunology is the most important corner. When I came back from United States in 2009, I was asked by Professor Ghunaim, what is the difference between Harvard environment and urology and nephrology center? I said to him, the difference is not in cystoscope, and not in nephrologist, and not in surgeon. The same surgery and the same nephrologist. But the difference may be in the immunology and the availability of immunological monitoring, which is costly, and the pathology. These are the two parts that need refinement. If we refine immunology, it may even may be more important than pathology. This is my points.
Thank you very much. And I think I will give now the discussions to Prof. Halawa. I am sure that he had a lot of comment and questions. Please, Prof. Halawa, if you
please unmute, yes.
Thank you very much for this elegant talk. But if you allow me, I have lots of comments. So
yes, go ahead, please.
Is it all right to go ahead? Regarding the Eplet or epitope matching, yes. In order to do it, we have to have high resolution typing. So basically typing 4 digits rather than 2 digits. And as a matter of fact, there's a lot of debate about the epitope matching. It's being used actually in Eurotransplant. In UK, it's not commonly used, but sometimes it's applied in highly sensitized patients. In Sheffield, we don't use it, in spite of having highly sensitized patients. Quite a lot of our patients are highly sensitized, but other centers, they use it. And actually, this is actually to answer to, Prof. Faissal Shaheen question regarding reduction of immunosuppression in failed transplant. The wisdom here is to check the epitope mismatch between the failed, in the failed kidney. And if there's higher epitopal mismatch, most likely this patient will develop DSC after reduction of immunosuppression. This is why you keep immunosuppression at a bit higher level. Non-compliance as well has been shown that reduction of immunosuppression with higher epitopal mismatch, most likely patient will reject. Most likely patient will develop since become sensitized. So it's not cost effective because it costs a lot of money as well. So just to do it. The second comment is improved cardio.
If you allow me, Professor Halawa, just to have sure. To reply to your comment, the first one. I like your comment, and I agree with you 100% that it is not easy to have this high resolution targeting 3 amino acid sequence like Eplets or triplets, whatever. And I explained in a video, special video for the HLA matchmaker and the Birch and the other methods for epitope mismatch. It is still investigational, and it needs a lot of money, a lot of experience. It's not an easy task. But from the rational point of view, it is rational. And I asked one of the big figures from the United States during our ES18 conference early this year, do you have Eplet and triplet mismatch? He said to me, we should have it, but we don't have it. So it is not available everywhere, but this is how the machinery is going. And I think we should cope with this advancement, even if for research purposes. And for the issue of repeated mismatch, I like your point, because the failing grafting, there are 2 points. Failing grafting may be a stimulus for formation of antibodies, or may be sinking, not maybe as absorbing the antibodies inside. And even when we decide for retransplantation, we exhaust ourselves to avoid repeated mismatch, because the mismatch in the first graft leads to graft failure. So in the second graft, we avoid repeated mismatch. Although there is a very nice article published last year about the value of repeated mismatch. The value of repeated mismatch was confirmed if there is donor-specific antibody. But our policy, no, we don't. If we decide for retransplantation, we review the tissue typing of the first donor to avoid any similarity with the second donor. This is what I would like to add.
But actually, I agree with this article, because this is what we do. We don't care whether there is a repeat mismatch or not, but we do care if there is donor-specific antibodies, because this is what really matters.
We adopt a more conservative approach, because we think of the tissue, the more the mismatch, the higher the likelihood of sensitization. So, yes.
The second, okay, and as well, is not only one epitope mismatch. Is we don't know what the cutoff is. 15 epitope mismatch is risky. 17, 6, 7. Everybody comes up with some figures and number, and there's no firm conclusion. So it's still in the air. And I agree with you. Don't forget, that our transplant population are different. So the people who are treating here is different from the people you treat over there, from Prof. Faissal, from Dr. Ahmed Akl. So, population are different. So we can't make firm conclusion based on one population.
But I think you agree with me, Professor Halawa, if we have two donors and the Eplet mismatch, and we will select the person with low mismatch.
Of course.
Yeah, of course. Yes.
No mismatch would be better.
Yes,
Dr. Akl wants to comment on the immunology. Yes, please. Yes, please, Dr.
I agree with Professor Halawa, and I agree with Professor Hussein. I am honored to be one of the committee that is working on the Eplet until now. I am working with Professor Rene, and of course, because I am away from the analysis of the antigens, I am responsible for the data analysis. And I have to tell you one of the secrets in the background, that HLA matchmakers is under development now for a new process, because it is not the degree of Eplets only, as Professor Halawa is trying to say, but also which Eplet can provoke the formation of antibody. So you may have a degree of mismatch, but not all Eplets you are identifying as mismatched Eplets can provoke antibody. So not all of them can formate or stimulate the formation of antibody. So this is under investigation, and we are working on this now.
This is a smart idea, Dr. Ahmed. Antibody verified Eplets, because not all Eplets are immunogenic, because we have immunogenic and antigenic, and there is a difference between antigenic and immunogenicity. Immunogenicity means the capacity to stimulate antibody formation. So we search for immunogenic ones that was proven to create antibody against it. And I think there are some data, even naive data, about the value of antibody verified Eplets. Dr. Akl.
I need only to comment on the expenses, because the HLA matchmaker is available for free from the website to be downloaded and even to be used. And also, I think most of the molecular data we are extracted for our recipients and donors already, they have data for even not 2 digits, or even for 6 digits. But what happened in the laboratory, that they give us the translation of the actual data coming from the machines. So the data, they reformat the data according to our knowledge. And for them, if you are used to work with the serum data and on 2 digits, they will give you the 2. If you need to do a 4 digits, they will give you the 4. If you ask for the 6 digit, they will give you the 6. But I think at 6 digits, you will not transplant anyone.
Absolutely.
And I would like to add to this complexity. We have the B Eplet and the T Eplet. Anti-Eplet, there is another software, not HLA matchmaker, it is PERSH2 scoring, so it is quite complex. But I think for research purpose, Dr. Halawa, the range should go. Train should go.
Okay.
Okay.
We have one question here which is related to this subject from our colleague Dr. Najwa about the accepted level of BRA class 1 and 2 to go for transplantation. So this is for Hussein or for Halawa, what do you think? Or Ahmed also?
I can answer.
Okay.
Yes.
Yes, go ahead. Go ahead, please. And
actually,
we have
in UK, nothing called PRA is gone, disappeared completely. PRA is completely dysfunctional because it targets only 50, pool of 50 donors, and is variable. There will be quite changes and differences between labs, not consistent. It does not give the real picture. But they're replaced by CPRA, basically, which is calculated panel reactive antibodies. And instead of having a panel of 50, you have panel of 12,000 potential kidney donors from the local area. And nothing called what's accepted, what's not acceptable. Everything is acceptable, but this is what we need to define it is which one is low risk, which one is high risk. Because, high risk patients should be transplanted as well, but we should be counseled, should be aware of complications, should be aware of rejection, should be aware of graft survival, and has an effect as well, and has influence on the type of immunosuppression you're going to give. So there's no cutoff for PRA.
Thank you. I think it's very important.
I agree with Prof.
To know that if we have someone with even what's named as high BRA, and he had a donor with negative cross-match, we should go and transplant him.
Absolutely.
This is his chance. So BRA is important,
Professor Faissal. Professor Faissal, the most important is the absence of donor-specific antibody, as you mentioned. Yes. But the presence of anti-HLA antibodies, even if it is not donor-specific, it is an index of immune response. So if the patient has high level of this calculated BRA and then transplanted, even if it is donor non-specific, we are not sure the immune system may form antibodies if the patient is transplanted and de novo DSA develops. This is why it is yes, we can proceed, but because we don't have calculated BRA in our country, because we don't have 12,000 patients, for them all tissue typing is available in transparent way to be used in calculator. We still depends upon the Luminex and others, so you can find percentage from here and there, and it is determined by the center policy. Dr. Akl.
I need only to comment what we did in France, that we estimated the BRA for the 6,000 kidney and pancreas came from all Europe, and we found a correlation, of course, with the donor-specific antibodies, but also the non-donor specific when they are at a very high level, they also correlate. And the reason for this is the cross reactivity between the specified antigens. And regarding the calculated BRA or CPRA, it is now calculated from the beads, because we have the Luminex beads that is used for the estimation of the antibodies. Each one of the beads is covered with one purified HLA antigen, and even it is so accurate up to the 4-digit level. So now we can calculate the CPRA from Luminex directly by using the beads, which is available around 120 for class 1 and more than that for class 2. And the level, as Professor Halawa, the confusing is the cutoff level. So at the University of Nantes, they are using 2,000 as a cutoff level, while in other centers, they use maybe more above that level or even below up to 400 like in Northwestern University when I went there. And what is the reason of this? This is simply because they need to correlate the result with the clinical outcome. So they are correlating the results of the BRA that is estimated by the beads with the cross-match results came from CDC. And each lab has its own sensitivity. So that's why the level or the threshold is different.
If you allow me, Professor Faissal, I would like to add here a point. Yes, we use BRA on the same assumption of HLA beads, like France. But the problem is, this is not our beads. This is not our HLA antigens. So calculated BRA, depending upon beads, is not accurate for Egyptian patients. So long as the beads is not produced from Egypt, it is produced from France or from Europe, so it is coupled with their antigens. So this is why it is better to have our HLA typing or to introduce our own beads that reflects the percentage of HLA distribution in our community. This is why I say that BRA calculated by Luminex in our center is not accurate like calculated BRA. Okay. This is what I would like to add. Yes.
I agree with you, Prof. Hussein. And I think some of our colleagues in immunology labs, they are doing our own test by our own patients, so in order to they accumulate all the patients doing HLA and take some sample from it. Some of them, they are doing this against our own patients. Any other questions from our colleague?
I still have few comments.
Yes, please, Dr. Halawa.
Yes.
So Dr. Halawa, then Dr. Akl.
Okay. Yes. Yeah. Number one, actually, you mentioned clearly that the cardiovascular mortality has improved, which is actually because patient selection. In the past, when we started the program in Liverpool, what happened? The kidney and pancreas program, combined kidney and pancreas program, high mortality rate, up to 40% of patients died. So we stopped the program for a year, and we discovered that our cardiac evaluation was not perfect. So we applied scrutiny into the cardiac evaluation, and this is how we got the program up and working very well. So it is an element of selection bias, because you transplant patients who are cardiovascularly fit, suitable for transplant, won't die after transplant. And this actually reflects on the post-operative mortality.
If you allow me, Professor Halawa, if you allow me.
Sure.
Don't forget that this is just a review for the most recent publication. It is not my opinion about all these subjects. And yes, I agree with you. There are many limitations of all publications. And there is no 100% accuracy. But when I say this is the data of 55,000, it reflects some points, and it reflects how the healthcare system is good and everything is registered. And this is one of our merits here. If we say that Urology and Nephrology Center is a strong center in transplantation, it is strong because of the good insight of Professor Ghunaim from the early beginning. Everything is digitalized. Even we have for each patient at any moment more than 300 variables for each patient. So this is why we can publish, why we can know the limitations, what is the problem. So this is what I reflected from the published registry is just the system. If you allow me, Professor Halawa, I'd like to give the mic to Professor Riyad Said, because he raised the hand from a long time. Dr. Riyad.
I cannot see him. You can see him. I cannot. Otherwise,
yes. No problem. Dr. Riyad.
مساء الخير.
We are glad that Professor Riyad is with us, and I'm expecting hot comments. Yes.
Well, really, thank you very much, really, for this elegant talk, which really I learned a lot from it. I start really with several comments, and I'm sure it has been discussed already. Concerning withdrawal of medication after we lose the graft, patient is coming back to dialysis and he lost his graft, what we'll do with his medications. I think I agree with what I heard from Dr. Faissal, and Dr. Halawa that gradual withdrawal of medication, starting with myclophenolate or mTORs. But please be careful, gradual withdrawal, not acute, the sudden stop, because we have a couple of incidents, acute rejection happened more and graft rupture, it can occur. So you have to be careful. Dr. Halawa, what do you think about this?
Of course, yes. Yeah. Nothing abrupt, because it won't be a good medicine. Basically, gradual withdrawal of immunosuppression. But again, based on the immunology of the grafts, and this is what we suggested, me and Prof. Faissal, based on immunology of the graft and degree mismatching, and also we talk about epitopial mismatch as well. So if immunological high risks graft failed, will be even with the immunosuppression will be withdrawn with care. So gradual withdrawal, and some of them actually in our center stayed on low dose TAC and MMF. So,
and if you allow me, the graft intolerance syndrome, we see many cases of graft intolerance. So this is why we keep steroid for a long period of time. We don't stop steroid. And if the patient came with tender graft and we evaluate by Doppler and we resume steroid and increase the dose of steroid because of graft intolerance. Graft intolerance may be tender graft, pain, and maybe anemia and others. So this is what we do. We should be gradual. And one of the important tip in practice is the presence of fistula. If the patient has no fistula, we should exhaust ourselves to keep the residual graft function up to because if we stop immune suppression, as Professor Riyad mentioned, we may even have severe rejection simulating graft abscess. So this is why we should be gradual in everything. Yes.
Okay, second point, please. I agree that every kidney biopsy that we should have, a core EM should be available. That's a standard of care. It's always, it's nice to come back and look, if you need it, you'll do it. If you don't need it, it's there. The second thing concerning if a patient will lose his graft for PK virus. Now, transplant nephrectomy before second transplantation, where we stand.
This is a difficult issue.
Nowhere.
As I mentioned, just a snapshot for the most recent publication. But if we go to BK virus related graft failure, we should monitor the graft, the PCR of the BK. We will not go for retransplant with the presence of positive PCR in the blood. And this is why we should repeat the PCR, and we can do retransplantation without graft nephrectomy if there is no active BK viremia in the blood. But it is a very debatable issue to do graft nephrectomy and to allow retransplant. It is a matter of experience and a matter of follow-up of BK viremia.
Yes, Hussein, I agree with you because I have one patient and I've been discussing this with my clinic. And I think this is the same way that you have to check the BK virus before transplantation. Once it is negative, you can go ahead and do transplant without graft nephrectomy. But if it is positive and consistently positive, probably you can consider graft nephrectomy in that case. Thank you for that you liberate this important point, Prof. Riyad.
Last thing.
Yes.
Last thing from my side, really, induction therapy seems to be the curve is going back again. That very little induction therapy is the current state of the art for the time being. And maintenance stack is the cornerstone.
I may disagree with you, Dr. Riyad.
Do you agree or disagree, you said?
Yeah, disagree. Because it depends on immunological status of the patient. If, there is increased number of highly sensitized patients now on the waiting list. So would you give them nothing at induction, or will you give them basiliximab? You should actually give them strong induction.
So the answer is one word: individualization according to the immunological risk of the patient. And I think the room for induction therapy is not restricted to this issue, but may extend to stopping to the refinement of immune suppression and stopping steroid even in non-highly sensitized patients. So I think induction is
But
still
I'll
there.
take the idea.
But yes, yes, Dr. Halawa.
The idea behind Dr. Riyad's talk, which is try to minimize the
Yes.
immunosuppression. So basically not to over immunosuppress patient, which is, nearly a common practice, a common malpractice that patients are over immunosuppressed.
Okay, Prof. Halawa, again, there is one question in the chat. It is for you as a surgeon. The indication the transplant.
Very nice. Very nice to have question dedicated directed to Professor Halawa. Okay.
Oh, sorry for that.
Yeah,
So,
I mean, from the talk here.
It is nephro and transplant, both of them. When you will decide to take the old graft out, when it is indicated?
When it is indicated, actually, graft intolerance syndrome. Basically, patient is not patient intolerant of immunosuppression. The graft is quite tender. Actually, one of the indication we may consider, which is still BK viral infection in spite of failing graft. Basically, these are the common indications for graft nephrectomy.
Okay.
Well, I think if you're going to go for a third kidney transplant, yes, you have to take one of the two.
Yes or no? Yes and no.
Yes or no.
You must put the kidney intraperitoneal.
Yeah, where are you going to put the third kidney?
Above and intraperitoneal.
Above.
So regarding graft nephrectomy, Dr. Faissal, if the graft failure occurs early after transplantation, so this is maybe an indication for graft nephrectomy, especially if there is hematuria and others. And for the long term, if the graft stayed for many years, then we assess the state. If there is severe graft intolerance or not, if there is impending rupture graft, there's an indication. But routine graft nephrectomy, I don't agree about routine graft nephrectomy. And I think Professor Halawa will add to this point, because surgeons hate graft nephrectomy because a lot of adhesions. Is it an easy surgery, Dr. Halawa, to do graft nephrectomy?
It's a horrible surgery because you are diving into scar tissue. You don't know where you are. Even more important than the surgery itself, when you do graft nephrectomy, you will find a surge of antibodies in the blood. So a patient actually becomes more sensitized immediately after graft nephrectomy. So if you can say that, the DSA will shoot up after graft nephrectomy because you're squeezing HLA and antibodies into the circulation.
Well, I think, again, if you allow me, one of the indications to do graft nephrectomy is high BRA. If the patient still have, from that graft, have a problem, I think this is one of the indications, which we were doing long time. Also, the other things is that if we have someone who with a graft failure and had, fever and lethargy and loss of appetite, and even if you give him a small dose of steroid, still he is going for that. Probably the best way is to take this graft out. Everything will return back again. This is maybe individual experience with also the patients who lost their graft.
Okay.
I agree with you, Faissal.
Okay. Dr. Akl.
Ahmed.
I think Dr. Faissal started the meeting and mentioning that the immunology was the third.
The first.
Factor in transplantation. And since then we are talking all about immunology. So
it is the first. It is the first hurdle. It is the first hurdle.
Understanding is the issue because all transplantation is an immunological debate. I need to say something. I don't know if Professor Hussein will be pleased or not, but when I started with him, he was the biggest one to send any transplant with graft failure to the surgery immediately. So I was surprised that 50% of our graft nephrectomy in Mansoura was done actually after referral from Professor Hussein, but he changed his concept and the ideas after that, and which is good. And really, it's not an easy and easy task to have this surgery, because we saw also on repeated ultrasound on the graft, we may find residual after the surgery. I don't know if Professor Halawa noticed that or not, but usually there is in the bed, there is some residual or hematoma after the surgery. And of course, the patient will stay for longer time to have his second or third transplantation.
If it is indicated, it's indicated, we'll do it. If it's not indicated, we'll do it.
It was old dogma. It was an old dogma that graft nephrectomy will be linked to better survival for the second transplant, but it is an old dogma, and we changed our mind. And I as you know, Dr. Ahmed, I cannot take the decision alone. We are team based, and we discuss together, and then we are the graft nephrectomy. The boss is a surgeon. So at the end of the day, after discussing together, then the opinion of surgeon will dominate at the end of the day, because this is how the things going here.
Well, I think it's two-way street, Hussein.
Yeah. Okay.
I think it's two-way street. You know, decision should be made, you know, in consideration, you know, both team, the surgeon and the nephrologist who take care of the patient. Ultimately, the front line for taking care of a patient is the nephrologist, and you are facing the family, you are facing the friends, you are facing everybody. The patient is under your care for the last 10, 15 years or so, and then the decision should be, you know, your decision should be really respected.
Thank you.
And there was a lesson from a terrible case that we advocate and stressed and insisted on graft nephrectomy, and the patient died after graft nephrectomy by a couple of days, and we regretted about the decision, but there was a frank indication for graft nephrectomy.
Okay.
So the lesson, the message is graft nephrectomy is not an easy task, and it should be controlled by both teams, medical and surgical. And at the end of the day, surgeon who is competent makes a big difference.
Makes your life easy.
Okay.
Yes.
Thank you. I think I have to deviate a little bit the discussions toward the COVID, since we are in a COVID era.
Yes. Yes.
I agree with you
Please.
about your you know,
Algorithm.
how you treat the COVID. I think we are doing the same. Myself and Akl doing the same. Usually we stop the MMF or we stop the azathioprine, and then we continue with the other medication, and then we return back to this medication. We have so many, by the way, so many patients transplant with COVID admitted to the hospital, and we are dealing with such patients. Fortunately, we don't have a lot of mortality on those patients. As far as, or maybe Ahmed can correct me. The survival was quite good on such patient, and usually we stop the Silset or mycophenolate or myfortic or even Imuran, and then continue with the other medication and a lowest dose, and then we return back to the same immunosuppression post-COVID when it is finished. So we are taking the same protocol you mentioned, and I don't know, either someone have another protocol or another thing to deal with COVID post-transplant, Prof. Riyad?
Well,
I was
fortunately, so far, really, we don't have a single case, but seems to be it's really surging in our area now. We registered 650 cases of COVID for today. So I'm sure our population is going to be on the rise. But I agree with you from reading, from what I hear, that yes, gradual withdrawal basically of MMF or mTORs should be the first line until your patient will recover. TAC will be the last thing really you reduce. You may increase the prednisone. I agree 100% with this. Fortunately, so far we did not have a single case in our area of this disease, but I'm sure we're going to face it soon.
Inshallah.
Thank you very much, Professor Riyad. I would like to confirm that mTOR inhibitors should be discontinued. Yes. Because there was a notion, it's not scientific at all, that mTOR inhibitors can lead to anti-COVID effects. We should stop them because even they lead to pneumonitis that may simulate COVID. And this is one the issue of cyclosporin. Cyclosporin interferes with SARS-CoV-2 protein, some protein in SARS-CoV-2, to the extent some centers prefer to shift from TAC to cyclosporin, but we decided to adopt low and accept the target of TAC, as I mentioned in my algorithm, and to stop TAC altogether if the patient is hypoxic on mechanical ventilation.
And rely on steroid therapy mostly, yes.
Okay, yes, steroid should be continued. And nowadays there are myriad of trials about dexamethasone, hydrocortisone, mesylbred. All these are proven to have some beneficial effects in treating COVID, severe COVID disease.
Thank you. Prof. Hussein, you mentioned important point about intra-abdominal hypertension. How to diagnose it actually? By what? By blood pressure?
By measuring? No. By measuring the pressure inside the urinary bladder. Urinary bladder reflects intra-abdominal pressure.
You mentioned that, but is it so frequent to do that, and why you are going to measure to have cystoscopy or to do what? Sorry for that native.
I don't measure it in here in ICU, but we can, if in the urodynamic studies, they measure it, but measured by another scale, centimeter water, and there is special manometry can be added to the monitor, and to know just on the patient both on 30 degrees, and then the bladder, and measuring the bladder pressure, and it is a very nice because intra-abdominal hypertension and abdominal compartmental syndrome can complicate major surgery. And if you document oliguria, acute renal failure with high intravesical pressure, this is an indication for reopening, for exploring the patient to release this pressure, because high intra-abdominal pressure reduces kidney perfusion, even native kidney. So this is one of the reasons. It may be one of the reasons why after doing a paracentesis for hepatorenal syndrome, diuresis occurs.
Okay,
I think you simply, what we use in measuring the CSF pressure, you connect your Foley catheter to a monitor, which is a tube, and you'll see you can read really the readings in the glass bead, the glass that you have. It can indicate 10, 15, 20, 30 a graded tube that we use basically for monitoring the CSF opening pressure when we have it. It's exactly in the same way. We have the Foley catheter in place and we connected.
Yes, some of our colleagues ask about this important issue that to be a little bit elaborated, and thanks.
Yes.
Thanks.
May I comment on this point?
Yes, please.
Basically, we are talking about measuring intravascular pressure as a surrogate marker of the intra-abdominal pressure. But we didn't ask ourselves, including myself, why we get into this point. Because we like to see our patients, overhydrated, overfilled. So a patient comes out of the operation, next day morning, 6 kilos above his dry weight. So we'll keep pushing fluid, and we like to see, is a passion to see the kidneys, that the patient is passing loads of urine. We don't know, actually we know, but we tend to undermine that fluid overload is a disease. And it is just, I don't know I will be treating myself because I do the same mistake. I know it's wrong, but still I'm doing it. That, I like to see more urine. But the problem actually is not only
this is the
heart, but
if you allow me, Professor Halawa.
Just a second, Professor.
Yes.
The wound,
yes.
Edematous, wound healing, the recovery of the patient won't be quite right. The lung, the heart, we are affecting every single organ of the body by fluid overload. And I wish that at some stage, I'll be brave enough to reduce the fluid intake, including the IV fluid, and to get the balance right. But still, I'm not brave enough to do it.
This is why I wanted to comment about this point. Here, for many years, we wanted to satisfy the surgeons. So surgeons everywhere is the reason behind this overhydration. And we should declare together, that overhydration is a biomarker for mortality.
That's true.
Not away from intra-abdominal hypertension and all these points. Volume overload is bad as dehydration. Both of them are bad. And if we are dealing with critical care, because immediately peri-transplant is the critical care period, and if we apply the principles of critical care, we should avoid this policy at all. 6 kilos, 7 kilos, it is very bad and may be problematic with blood pressure. And if we give antihypertensive treatment, this may even increase the risk of dehydration and viscosity and thrombosis. So it's better to stop this dogma. And fortunately enough, these days, we are controlling ourselves and as nephrologists, and we stop the policy of overhydration because the pressure of the surgeon is now released a little bit.
No, but Hussein, I think if you want to do that, you have to attend the surgery. You don't know on the surgery.
Yeah.
Always, he said, push fluid all the time.
True.
All the time, give fluid. And then the patients come out with 6 kg overweight, as you mentioned.
I think there's a short period after the clamping. And if we satisfy the fluid at this point, it's okay, but not to continue for them.
They won't see the urine.
Yes.
Yeah, just so you know, we're treating ourselves. We like to please ourselves by seeing more urine, but we don't know that we are damaging the heart, damaging the lung, cause wound-related complications. Patients get DVT, intra-abdominal compartment syndrome, graft dysfunction, and even transplant compartment syndrome by overzealous fluid infusion. I think it's difficult to deal with surgeons.
Okay.
Not really. I think they are our friends.
No, they are not friends. They are enemies.
No.
They are our enemy.
Honestly, when you have good working relation, they are basically your right hand. We cannot really, work without them. They cannot work without us. It's a teamwork.
Okay.
It is a joke. It is a joke, Professor Halawa. It is a joke. It is not one-man show. It is a teamwork.
That's exactly.
Thank you very much. I think I enjoyed all the discussion, and I don't know, Prof. Hussein, when he will allow us to close the session. He is the one to.
No. You are the boss. You are the boss today.
Do you mind, Dr. Faissal? I would like just to make a final comment on very important issue, which is Clostridium difficile, CDEF.
Yes.
Basically, the guidelines suggested vancomycin as first line of treatment. However, metronidazole is cheaper, and in other centers they use it. But the most important point which I would like to make, failure of treatment with abdominal distension and tenderness dictates to call the surgeon total colectomy. So we shouldn't keep treating patients medically and abdomen is distended, and CT scan showed that the transverse colon is more than 7 centimeters in diameter. This is megacolon. This is where surgery is indicated rather than to carry on medically treating them.
It was present in the slide, but I didn't read it. That with the fatal cases, surgery is indicated, and even fecal transplantation is an issue to control. And there is, I think, outside the transplantation, Clostridium difficile. Dr. Halawa, Dr. Akl.
Please.
Dr. Akl raised his hand. Yes.
Because when you said the stool transplantation, I will come back. My first question. Because when I went to United States, this was on the top of the research. And even I remember my mentor in one of the sessions, he talked to me in my ear and told me, "You are lucky that you are not working on that field because they were all related to stool transplantation." But I think this light were shed off when one of the cases got infected after the stool transplantation. But I am interested in my first question. which is related to probiotics. Is it safe in transplant recipients, and which one we shall use if we are going to use it? For example, some transplant recipients with chronic diarrhea, or we feel that his microbiota is not healthy, and we want to replenish his microbiota. As you said, Professor Hussein, which probiotics we use? Everything is available for the transplant or not? So up to my knowledge, and everyone can correct me, that there is some not all are good, but some are only safe, especially the non-spore forming probiotics. So what do you think about this issue?
If so long as you ask this question, I'd like to declare that many of the products in the market named as probiotic are fiction, medicine fiction. They have no bacteria, nothing. So we should be sure about this. And the majority of studies in transplantations are basic research. This is why I am convinced by prebiotic fibers, because fibers can even encourage Treg cells. So after the short period of transplantation, after the 3 months of transplantation and everything is fine, I encourage transplant recipients to have food full of fibers rather than probiotics. But which type of probiotic to be used, I think I should review the literature because I don't know. And I have one of the articles mentioned many names from the market with devoid of any bacteria. Dr. Faissal, where is Dr. Faissal?
Here, I can see
yourself. Unmute yourself, Dr. Faissal, please.
Yeah, I am with you, but I cannot unmute myself.
Is there any further comment or question?
I think we cover very well the new aspect of renal transplantation, and thank you, Hussein, for this new data, which I believe that you are. I don't know how you managed to collect all of this. Excellent talk, excellent discussion, and thank you, and thanks for all our colleagues from all Arab world. And thank you, Dr. Halawa, from over there a long period, but you are always attending with us. Make us happy to see you and to have another complete view also from your side. Thank you, Riyad, Akl, for your contribution. And I think by this I will close. I don't have certificate to give it to you, but your certificate.
No. I just give me one minute. Just yeah. I would like to thank all attendees from Egypt and Arab world, Professor Akl, Professor Riyad Said, all my colleagues, and Professor Halawa is unique in his style. He is completely different. He is medical and surgical, and I love him very much. And I want to announce that in a couple of weeks, 22nd of October, he will speak about the immunology. So this is an invitation for Professor Akl to be with us in this meeting, and he will summarize the many pitfalls from the immunological aspects of transplantation. We are eager to hear from him. I would like to thank Professor Faissal Shaheen for his excellent moderation and for his continuous support for our CME program. Really, I like your style. You are encouraging and the supporting for this meeting. And this is just a symbol of respect from the Egyptian Society of Nephrology and Transplantation CME chapter, and appreciating your presence with us and the questions and the comments. All your words are very valuable, and your attitude to support us is really appreciated. Thank you very much. Hoping all the best for all my professors and colleagues and all Arab world and all who will hear the video on the tube. Thank you and goodbye.
Thank you. Thank you. Bye-bye.
Thank you very much. Thank you. Bye-bye.
Bye.